Good morning, everyone. This is Ashley Harris from the New England QIN-QIO, and thank you for joining us for today's learning and sharing call on data and QAPI. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we will take questions at the end. I'll provide you instructions on how to unmute your phone line then. I'd like to introduce our first speaker, Lori Nirbaum. Lori is a registered nurse with several years of experience in patient safety, policy, and patient advocacy. She has a passion for helping people with quality improvement. I'll now pass it over to Lori to begin the webinar.
Thank you, Ashley. Welcome, everyone. It's a pleasure to be here with all of you today. We're so excited to dig in and talk about data and all of its uses in your quality improvement journey. But before we get started, I'd like to first review our learning objectives for today. At the end of our sharing call today, we feel pretty confident that you'll be able to understand the nursing home quality measures and identify opportunities to improve your 5-star quality rating. You'll learn how to use data to monitor and evaluate QAPI program performance. Use data as a tool to build relationships with hospitals, ACOs, and other partners, and hear from other participating nursing homes and teams on how they are using data to drive quality improvement. I'd also like to add that we use an all-teach, all-learn style during our webinars, which is interactive. We have some of your colleagues on our call today to share their data and project improvement successes with you. And we invite you to ask questions or comments using the call-in or chat feature. We want to impress that this is your forum to learn, teach, share, collaborate, and have some fun. To begin, I'd like to highlight a new downloadable tool that we have recently posted on our website. It's called Navigating the Collaborative Checklist. This is a tool that was designed to help guide you and your staff through each learning series of the collaborative with easy-to-understand instructions and graphics. You can use it as a navigation tool and a communication tool. It can be placed in your facility's QAPI binder, posted on a staff bulletin board, or emailed to a unit manager. Ashley will be putting the link to the Navigating the Collaborative for you to download, and she'll be putting it in our chat session. If you have creative ideas for how you spread information about the Nursing Home Collaborative or your QAPI activities in your facility, please let us know in chat. It's hard to believe that we are already midway through Phase 1 of the first 18-month learning collaborative with a focus on safe care transitions. We hope you've been fully engaged with our pre-work activities, completed your QAPI self-assessment and charter, and had the chance to view webinars or learning modules over these past 5 months. So far, topics have covered QAPI, safe care transitions, preventing healthcare-associated infections, advanced directives, and end-of-life care. If you've had a chance to participate as fully as you'd like, please know it's not too late. If you haven't had the chance to participate as fully as you'd like, it's not too late. All of our webinars and learning modules can be accessed on our website at your convenience. And remember, they are all free to you and your entire staff. The link to our website is provided at the end of the slide deck, and remember to download the navigation checklist while you're there. This is another glimpse of the Navigating the Collaborative Checklist tool. You can see from the graphics that we are nearing the end of Learning Period 3 very soon. By using this checklist as a navigation tool, you can select the links, the active links, which are highlighted in blue, to QAPI pre-work activity, webinars, or learning modules for past or present learning periods. It's a quick and easy way to catch up, continue moving forward, or know what's coming ahead. As we come to the end of Phase 1, we'll have 2 face-to-face learning and sharing days for our Outcomes Congress. Please mark your calendars and join us for October 29th or December 3rd, 2015, when these 3 topics will be covered: value-based purchasing, star ratings, habilitation therapy for dementia care. We're planning for this to be an interactive day in which you can participate in panel discussions and hear inspiring patient stories. Look for invitations coming via email, in our WINK newsletter, and announcements on our website. CEUs will be provided, and we really hope you can join us for these timely topics. So why is data important? Well, do you know your nursing center's quality outcomes in comparison to other centers within the state and nationally? Or how does your QI committee know that the process or systematic changes that you are making have led to improvement? These are questions that can be answered by looking at your nursing center's data. There are several important healthcare policy factors that are driving your current quality improvement efforts. The proposed rule for new QAPI regulations will require nursing homes, quality assessment, and assurance committees to use QAPI techniques to monitor and evaluate performance, as well as keeping written documentation. Value-based payment programs will use quality measures to determine payment incentives or penalties. Penalties and payments start in 2018, but measurement will begin on your data starting in 2016. The 5-star ratings allow comparisons of your facility to those in your state and across the country and are reported publicly on the Nursing Home Compare website. As we all know, the star rating system changes have raised the bar for nursing centers across the country. ACOs and hospitals are focusing on data and star ratings to inform who they will refer patients to, and consumers are using star ratings to compare facilities when they decide who will provide care for their loved ones. ACOs, bundled payments, preferred providers are all newer concepts that will impact your referral sources as well as how you are paid to care for patients. The important thing to remember is that the value of data is its use in helping to improve your facility's performance and resident or patients' lives. And that's what we all want. So care transitions occur when patients move from one healthcare provider or setting to another. Nearly 1 in 5 Medicare patients discharged from the hospital, approximately 2.6 million seniors, are readmitted within 30 days at a cost of over $26 billion a year. These economic and quality of care realities are some of the factors driving a new focus on quality and value over the former quantity of care and fee-for-service model. What does this mean for you? As you can see from the graphic on the right, the focus is on using data to arrive at solutions to drive improvement, and it requires communication and collaboration across all healthcare settings. Whether it's reducing readmission rates, improving your quality measures, improving medication safety, the end result is working together to improve the quality of life for all patients as they move through the system. And I think we can all agree that that's a good thing for patients. So how do we use data? Well, we use it to measure clinical outcomes, drive quality improvement, monitor improvement, evaluate progress, and we sometimes use it as a marketing tool. But how does data do this for us? By pulling all your different sources of data together, you begin to see your facility's quality story. And what do we do with stories? We share them. We get people together to discuss them, and in the case of QAPI, you can bring your quality champions together to act on what the data is telling you. It may be telling you to celebrate your successes with your staff, or it may be directing you to focus on the opportunities that you have to improve. Analyzing multiple sources of data can help you to choose what performance improvement project or tip that you will work on. in summary, once you know your data story and where you stand with opportunities to improve, then QAPI provides you with a roadmap to implement change. That's why we suggest compiling a QAPI binder and putting it in a prominent place that everyone in your facility can easily access. It has all the tools and resources that your QAPI team and staff will need to drive improvement and improve patient outcomes. Using data in QAPI helps to identify opportunities for performance improvement projects. It helps you to track your PIP progress, and it tells you what your end result is. Are our changes working to get the results that we want? Tracking data when you implement a PIP answers the question, how much did we decrease use of antipsychotics? Or did we see a decrease in infections in our unit over the past 3 months? So now that we've covered why data is important and how it's used in your QAPI journey, I'd like to introduce Sarah Durenik, our program administrator, who will dive deeper into this data discussion with you. Sarah was a nursing home administrator in California for 5 years before joining the QIO this past December. She has a passion for data analysis and sharing her knowledge with others.
Thank you, Lori. Good morning, everyone, and welcome. We talked about data during our learning forum last month, and you all expressed interest in learning more, which is why we're all here on this call today. Before we take a deeper dive into our discussion on data, I wanted to highlight one of our participating nursing home teams. I was going to introduce Andrea Rathbone, the administrator at Untitled Senior Care in Lowell. However, she got pulled away at the last minute and was unable to make it to our call, so I will do my best to share their story on her behalf. The Untitled Senior Care participated in a demonstration project implementing a QAPI program within their nursing center, and Andrea wanted to share with everyone some of their best practices and discuss some of the challenges they face along the way. Before implementing QAPI, their QI team met on a monthly basis. They would use data to report on their quality measures, but didn't talk about plans for improving. So they created a dashboard to track their goals, which they now use to start each meeting. They've changed their overall approach to all meetings and look at quality improvement proactively. They also have a great team process and established teams for performance improvement projects when they identify a quality measure or outcome that is not met, or if the staff is not happy with the process. Sometimes the PIP champion isn't identified right away, but once they meet with the staff and talk about the issue, their champions naturally rise and stand out. I want to thank Andrea and the team at Untitled Senior Care for sharing with us their successes, and we congratulate you on your reduction in antipsychotic medication use. Keep up the good work. We'd like for the webinar today to be interactive, so I want to encourage you to use the chat throughout the presentation. If you have a question or wanted to share best practice or challenges you've experienced, there will also be a sharing session and Q&A at the end if you prefer to write or share your experience then. This is a learning collaborative, and we really encourage your sharing with one another. You also have access to clinical data, including quality measures through the MDS database, and depending on which MDS software your nursing center uses, you may also have access to various reports. Some of the data sources we will be talking about today include Nursing Home Compare, which publishes 18 quality measures, 11 of which are used in the formula to calculate the 5-star quality rating for each facility. The quality measure list on Nursing Home Compare comes from MDS data. Casper also gives access to both providers and surveyors facility-level quality measure reports. I will go into more detail on these reports a little later. Also, you should be receiving from us your quarterly standard analytic report, also known as the STAR. Another data tracking system that we'll discuss is the fact that you can also track your own data using weekly logs and other resources that you have available in your facility. We're all familiar with Nursing Home Compare and the star rating that is published for each Medicare and Medicaid licensed nursing center. Nursing Home Compare's 5-star quality rating system incorporates data from 3 domains: health inspections, staffing, and quality measures. These domains, each with their own rating, make up the overall star rating for each nursing facility. I'm going to talk a little more about quality measures and the methodology of the quality measure domain and to help you understand how to identify opportunities to improve clinical outcomes and how those improvements will impact your star rating. Quality measures are intended to help improve resident care and in turn will improve resident satisfaction. 18 quality measures from MDS data for the most recent 3 quarters are published on Nursing Home Compare, 13 of which are measures for long-stay residents and 5 are for short-stay residents. This is a list of the long-stay quality measures published on Nursing Home Compare. 8 of the 13 long-stay quality measures highlighted here in red are included in the 5-star quality rating. This includes the percentage of long-stay residents with an increased need for help with ADLs, high-risk long-stay residents with pressure ulcers, residents experiencing 1 or more falls with major injury, and the percentage of long-stay residents who received an antipsychotic medication. Out of the 5 short-stay quality measures published on Nursing Home Compare, 3 are included in the 5-star quality rating. Again, those are highlighted in red and includes the percentage of short-stay residents with pressure ulcers that are new or worsened, residents who self-report moderate to severe pain, and last but not least, the percentage of short-stay residents who newly received an antipsychotic medication. So who is looking at your quality measures? Your quality improvement staff use quality measures to identify and track opportunities to improve resident care internally. Surveyors will use the quality measures as part of MDS-focused surveys to inform the survey process and direct surveyors to concentrate on areas of concern that are identified by the quality measures. Residents and family members are looking at your quality measures on Nursing Home Compare. And finally, your referral sources, hospitals, ACOs, etc., are looking at your quality measures before referring patients to you. Lori mentioned earlier that the SNP value-based payment program is coming soon, which will also look at quality measures. So we're talking about quality measures and how they impact your overall 5-star rating. We look at the steps to calculating your overall star rating based on the rating for each of the 3 domains. You will find that there is an opportunity to increase your overall rating by 1 star if you achieve 5 stars in your quality measures rating. And I know that for most of you on the call today, you are not as far off from this as you might think. So real-time quality measure data, and when I say real-time, I say that lightly, which I'll explain. You have access to facility-level quality measure reports in Casper. You will want to review the quality measure reports with your team on a regular basis to monitor your quality measures and determine if you have a facility-wide problem or is it a resident-specific problem. The MDS 3.0 quality measure reports can be downloaded on the reports page in Casper. There are 3 reports that you will want to pull: the facility characteristics report, facility level quality measure report, and the resident level quality measure report. You are able to specify the reporting time frame for the reports. State and national comparison group data are calculated monthly on the first day of the month, and data calculation is delayed by 2 months in order to allow for submission of late and corrected assessments. The facility characteristics report identifies potential areas for further emphasis or review as part of a survey or your nursing center's QAPI program. It provides facility demographic information and includes comparison state and national percentages for a specified time frame. By comparing the facility percentages with the state and national average percentages, you can determine whether the facility's demographic characteristics differ from the norm. Facility characteristics may indicate a need to concentrate a review on a certain resident group. Examples of this include a very old population. Massachusetts specifically has one of the highest populations with residents over the age of 85. Also, an unusual high percentage of male residents, where you might have a higher than average percentage of residents with psychiatric, intellectually disabled, or developmentally disabled diagnoses. Or you might have a higher than average percentage of admission assessments, which might mean that you're either getting a high volume of short stay residents, or you might have a high readmission rate. Understanding your facility characteristics will help your quality improvement team when discussing quality measures with residents, family members, and your referral sources. The next report is the MDS 3.0 Facility Quality Measure Report. For each quality measure, this report shows the facility percentage and how the facility compares with other facilities in the state and in the nation. This report helps facilities identify possible areas for further emphasis in quality improvement activities or investigation during the survey process. This report displays the quality measure numerator and denominator counts for a selected period. It includes the facility's observed and adjusted triggered percentages, as well as state and national average percentage comparisons and a national ranking for each measure. It's important to note that the national percentile column ranks facilities relative to other facilities in the nation on each measure. The higher the ranking, the more likely the measure should be reviewed as part of your quality improvement process or may be emphasized on survey. Some of the values in this column may be highlighted in bold font. This identifies those measures that cross an investigative threshold. Quality measures at or above the 75th percentile in this column are designated in bold font. This identifies those measures where the facility's ranking is high enough that it should be investigated or emphasized on survey or in any internal quality improvement initiative that may indicate a possible concern with regard to quality of care. Your quality team should focus on these quality measures when reviewing these reports. And lastly, the MDS 3.0 Resident-Level Quality Measure Report identifies the residents, both active and discharged, that were included in the calculations for the facility and the period that were used to produce the report. This report lists the residents by name and indicates the measures, if any, triggered by each. The resident-level quality measure report can be used in two ways. First, it can be used to identify residents that trigger a particular quality measure by scanning a column of interest and looking for the residents that are marked with an X. Second, it can be used to identify residents who trigger multiple quality measures. Such residents may merit special consideration or more intensive review. Often you will find that residents who trigger the antipsychotic measure will also trigger 3 or more other quality measures. If you had any questions on what I'm discussing during this presentation, or if you're looking for more details about each report, please refer to the CASPER Reporting User's Manual, which we've provided a link to at the end of this presentation. Getting back to your 5-star quality rating, rating system again uses 11 of the 18 quality measures currently posted on the Nursing Home Compare website to calculate the rating for the quality measure domain. For scoring quality measures, CMS uses fixed numeric thresholds as the boundaries between the star categories. You are able to see the number that you need to attain in order to move up by 1 star. Facility adjusted quality measure scores are based on a calculation which combines the facility level expected score and the facility level observed score. The 5-star rating technical user's guide includes national and state ranges for the point values. Here is an example of how to determine the point value for the long-stay antipsychotic medication quality measure. For each measure, 20 to 100 points are assigned based on facility performance. Facilities are grouped into quintiles based on the national distribution of the quality measure. The quintiles are assigned 20 points for the lowest and 100 points for the highest. Physical restraint and short-stay pressure ulcers quality measures are based on state distributions of the quality measure, not the national distribution. Again, we're reviewing this to give you an understanding that you are able to determine the number or quality measure percentage that you need to meet in order to move your overall 5-star rating up 1 star. The technical user's guide will walk you through this process, which we also have a link available at the end of this presentation. Another important note is that values for the catheter, long-stay pain, and short-stay pressure ulcers are risk-adjusted. So once you've identified the points for each quality measure, you will add together all points for a total point score, which is also called the quality measure summary score. Once the summary score is computed for your nursing center, the 5-star quality measure rating is assigned according to the point threshold shown in Table 7 on the slide from the technical user's guide. Based on this total score, the top 10% of nursing homes nationwide get 5 stars, and the bottom 20% get 1 star. In the middle, 70% of the nursing homes receive 2, 3, or 4 stars, with an equal proportion in each category. The thresholds for this distribution are also fixed rather than being recalculated each month. This is where you will determine the number of points you need to achieve 5 stars for your quality measure rating, and then you can go back and take a look at which quality measures you can move up into a higher quintile in order to earn more points and increase your overall score. Should you choose to calculate your score for quality improvement purposes, it's important to consider those quality measures that relate to one another. An example of this would be the long-stay quality measure on antipsychotic medications. As a QIO, we use quality measures to track nursing center performance, and we've noticed that when the antipsychotic rate improves, other quality measures improve as well. For example, UTIs, pressure ulcers, ADLs, etc. The American Healthcare Association has a really great tool available for members to help calculate this for you. A little complicated, so check out the website if you're a member. The tool is very user-friendly. Getting back to QAPI, your quality committee will be required to have a QAPI plan for monitoring and evaluating performance. The New England QIN-QIO provides to those nursing centers participating in the collaborative a quarterly standard analytic report, the STAR. The STAR includes quality measure quartile charts that provide a snapshot of where your nursing center stands in comparison to other nursing centers within Massachusetts. It also includes charts for you to track trending of your facility's performance over time for all 13 long-stay quality measures starting in Q2 of 2013. The most recent STAR that was shared with you in late May plots trending through 2014, and you will receive later this week an updated report that includes data through Q1 of this year. And I'll show you an example of these charts in the next slide. The STAR can be used to identify opportunities to start a new PIP, and is also a helpful tool to monitor and evaluate the changes you implement to determine if, in fact, you are achieving improvement. This slide includes one of the QM charts that you'll find on the STAR. What makes this report useful is that you are able to track performance on each quality measure over time to see if you are improving. Continuous monitoring and reporting of data has many uses. It helps identify opportunities for improvement, helps you understand your 5-star quality rating and identify opportunities to improve your overall rating. You're able to monitor and track changes and evaluate improvement. Another opportunity for using data is as a marketing tool, as Lori expressed earlier. We encourage you to share data with your referral sources and family members and residents. Identify those areas that you've made improvement and show them how you've improved. Let the data tell the story. Don't forget to look at your facility characteristic report in CASPER to identify areas that might argue a high quality measure. For example, you might have a high population of residents that are over the age of 5, or you might have a high census of hospice residents. In addition, facilities that follow this path of monitoring and evaluating data will meet the requirements of QAPI. So while QAPI will soon become law, there's a real opportunity to drive continuous improvement in every corner of your facility's operations. Resident and family satisfaction data is something we haven't talked too much about, yet it's important that residents, family, and even your staff are given the opportunity to address the quality committee and participate on quality improvement projects where they are directly involved, or staff can participate on projects where they've expressed interest, where you find those champions. So now what? Now that you know what data is available for you to use to help set performance targets and you've selected which specific quality measures will be used for your quality initiative, the next step is to develop your performance improvement projects. This allows you to build a plan, do, study, act, or PDSA cycle for this specific skill and care practice. This rapid cycle improvement allows you to review your results and based on those results, abort the change, adapt the change, or adopt the change. The performance improvement project can relate to a quality problem involving few residents, one area of the center, or center-wide. Your PIP team leader or champion needs to be identified as well as the time frame for reporting progress. The project improvement goals need to be stated, resources identified, as well as data used for monitoring and evaluation, how you plan to communicate improvement efforts to staff, residents, and families, and others, and show how quality improvement work will be incorporated into existing assignments. The change package, which we've linked on this slide and also made available to you on our website, is a menu of evidence-based strategies, change concepts, and specific actionable items that any nursing home can choose from to begin testing for purposes of improving residents' quality of life and care. Since the collaborative is all about sharing with one another, I wanted to highlight that this change package also includes a success story template. As you test action items from the change package, document your success stories and share them with us to help spread improvement and best practices across the state. The success template is included as an attachment to this document. So the bottom line is that there will be a regulation and you will need to have a written QAPI program. Your QAPI program must be data-driven and engage our staff, residents, families, and others, and focuses on continuous improvement and sustainment of identified risks. We are providing you with a method to have a written program that incorporates the QAPI 5 elements. To access and download the QAPI program packet, you can visit our website, healthcarefornewengland.org. We've also provided a link on the slides that you should have received on a link earlier, in an email earlier today. If your team has not yet completed the QAPI self-assessment, you will also find a link to the survey on our website. Self-assessment is a useful tool that will identify things like who has received formal training on QI techniques, who the dedicated person is for QI in your facility, what data or other materials do you need, and identifies any barriers or challenges to implementing QAPI that you need to address with leadership. I'm going to turn this back over to Ashley to open up for our sharing portion of this call. Thank you, Sarah. At this time, we'll take a few questions. If you'd like to ask a question, please press *6 on your phone to unmute your line.
So the title of our sharing call today is that it's a sharing call around data, and we really welcome any of you who have implemented any project improvement plans or are using data to drive improvement in your facility. If you have any stories you'd like to share, please do so. We'd love to hear from you. Do we have any calls?
As a reminder, to unmute your line, press *6.
So I'm wondering if we have Susan Gonzalez on the line. Susan, if you're on the line, could you unmute your phone?
Hello?
Hello, is this Susan?
Yeah, this is Susan, and I have my Assistant Director of Nursing, Terry Moran, with me. And yes, we would like to share our success. Hello?
I just wanted to say thank you for speaking up and sharing. Go ahead.
Oh, you're welcome. Fortunately, we have a very low, our scores are, fortunately continues to be low when compared to the national and the state average. Basically, we started with our care from the moment the patients or the residents come to our facility. We do this as a team approach, and we care for the residents as a whole. So the moment the residents come to us, we do a care planning right within 24 to 48 hours, so that the expectations, find out what are the expectations of the family, and gain information from them, and then create a care plan for the residents. The thing about it is that the self-education and getting them involved with the care of the resident is the key. Yes, we don't use a lot of data, but we do look at our quality measures, quality indicators monthly, and see if there's anything else that we need to improve. But I think at the beginning, if we set up the expectations and educate our staff and then have them involved, the data will speak for itself at the end. So at this time, our pressure also, of course, because our goal is preventative. Our infection rate is very low.
Yeah.
If Gary can speak about that as well.
Yeah, we have actually had very little infections. We have not had any drug-resistant infections in years here. And we also have a yogurt policy where we have a homemade yogurt we use here. Anyone that goes on an antibiotic automatically goes on the homemade yogurt for a week after, and we've had no C. diff at all in this building. We don't do all the other probiotics and things, because we have our own recipes here that we follow.
The other one too is that a consistent assignment, that's very important, that the staff knows about the resident from the moment the resident is admitted to the facility, and set up an expectations again and continuous follow-up about that. So basically our goal in our facility is to track the data on a daily basis or regular basis, work on it, and to work with the family, treat the person as a whole, involve the other disciplines to be part of the people that are going to treat the resident, and of course the family. So as a result, we have a family and residents that are happy and content, because then we need that information, and information that we can get from us in regards to caring for their loved ones. So the data that help us when we check that, but basically, like I said, what we do here drives the data speak by itself. So the self-education is very important, whether it's self-education continues and ongoing, whether to address a need as it arises through in-service training or in a more formal classroom type experience, such as the mandatory yearly dementia care training that is given to all employees at Bethany. So not just nursing. So this based on the skills of our staff and enable us to minimize also staff turnover.
Susan, it sounds like you're doing some incredible on-hand work as well as using the QAPI process and data tracking, you said, on a daily basis. And I want to acknowledge and thank you so much for sharing that. I do want to let everyone on the call know that Susan Gonzalez is the Director of Nursing Services for Bethany Healthcare Center in Framingham. And Susan, I'm sorry, but I didn't catch the name of the staff person with you. Could you introduce her as well?
Oh, I'm Carrie Moran, one of the assistant directors of nursing.
Thank you, Carrie. Does anyone have questions for Susan or Terry on the line? Please unmute your phone. Any questions? You press *6 on your phone and unmute.
Is there a recipe for that yogurt?
Yes.
So that's a wonderful question, and we will reach out to Susan and be sure that we get that to those participating in the call today if Susan's willing to share it. That's a wonderful question.
I'd like to share that with you.
Thank you.
Actually, it's a very simple one, and I know we don't have what do you call that, a data that will support that, but all I can say is that we have not had CDIF in this facility. I don't even remember when. We have admitted a resident with CDIF and we were able to look at it. Yeah.
So I will definitely share that.
Thank you. Thank you both. The other thing that I just want to point out about your conversation was it seemed to me that the theme that you was repeated throughout was that you really engage your residents and families in a lot of the quality improvement decision making. Do you have a resident family council that you use, or can you just tell us a little bit more about how you engage your residents and families?
Well, first of all, I developed a palliative care team at Bethany because this is a long-term care palliative care, which I believe that is being encouraged in the long-term facility. So basically, when the residents come to us, even whether they're short-term or long-term, there's always another comorbidity, or that goes with their present diagnosis. If not also, if they are coming to us in long term, that's a big adjustment to the family and the resident. So what would we do? We treat the family and the resident as a whole, meaning we treat the pain, different kind of pain, the physical pain, emotional pain, familial pain, mental pain, because there's a big adjustment for the life of the resident and the family. So we meet with them at the beginning and we assure them that we are here for them. Now, that alone helps the resident and the family kind of close that fear that, okay, I'm going to the unknown place, that, we introduce our team to them and we tell them that this is the team that are going to be there for you and your family. So, we establish that from the beginning so that they will feel like, we are all there for them.
To make sure how a family meeting within 48 hours of their admission into the building. So it's done right away.
Yes. And the question to you is your family council. For the dementia care unit, because we have a special care unit, yes, we do have a family council because this resident cannot be participating with us with the family council. And I'll tell you, it's a very successful group. At the beginning, there's few, but now we have a big group coming. And even family members that will no longer have their family here, they come and visit us, and they come as a support to the family members that still have their family at Bethany.
And what we do is we have the family meeting, council meeting. It's done quarterly, and the first half hour to 45 minutes, I actually do education for the families, and they give me a topic, and I do education, and then the second half, we leave and they have their family council.
Wow, well, it sounds like the patient-family engagement piece that you're doing, as we are coming to know, does really contribute to quality of care, and it sounds like at Bethany this is something that's really happening in your facility. It's a real testimony to the care you're providing if you have these families coming back, even when they no longer have a resident there. That's a real compliment.
Yeah, thank you. The foremost that we stress is that our facility is a resident's home, and we try to treat them as a resident as we treat our family member. So I'm very happy to have the staff, CNA and nurses that embraces this philosophy. Thank you.
I'm sorry, I didn't mean to interrupt you. Go ahead.
I mean, I think, treating them like a family members, things are just fall into places if we start with that kind of approach. Engaging our staff, and be part of along the way, be part of the team. For them, especially the CNA, because they are the first and foremost caregiver, and so. Any question for us?
If you have questions for Susan or Terry, you can press *6 and please unmute your line. Thank you so much for sharing that great information with us, both of you, and taking the time to prepare for today. I want to compliment you on the care you're providing and for sharing it with all of us so we could benefit. Thank you.
Awesome.
Are there any other questions for us? *6. If there are no further questions at this time, I'm going to pass it back to Sarah, who will share some further resources with all of you.
Hello? Hello? Hi, this is Angela Tavares. I'm one of the nurse case managers calling from Life Care Center of West Bridgewater. We just had a quick question on post-acute pain, the quality measure for post-acute pain. Okay. So in regards to the post-acute pain quality measure, our population is primarily post-operative patients that are approximately 2 to 3 days post-op, and now with the ACO waivers, we're seeing even, 1 to 2 days post-op. So their initial pain interview is definitely skewed and in a moderate to severe pain. Are there any risk adjustments that are looking to be done so that we're not all triggering so much for the post-acute pain?
So you're not alone. I've had this conversation. I think I have this conversation every week with a new person.
That's comforting. That's comforting.
The first thing, one best practice I heard from one facility was that they used to, their MDS nurses kind of changed their calendar because they needed to get the nursing staff to get to know the patient after the first couple of days and get their pain controlled before they did the initial admission assessment. We have several training tools and videos that we can share with you on the MDS assessment in that particular portion of the MDS.
That would be everybody. Yeah, that would be fantastic.
We'll share that with everyone in a email follow-up, including that yogurt recipe.
Thank you.
You're welcome.
Thank you. Are there any other questions on the line? Just press *6 and unmute your line. At this point, if there are no further questions, I will pass it back to Sarah, who has some great resources to share with you.
We wanted to remind you all that registration is now open for the upcoming OASIS training led by Mass Senior Care. This will be the third and final round of OASIS training that's funded through a DPH grant. You can register through the Mass Senior Care website. We've also provided contact information on the presentation slides as well. I hope you've found this information from the webinar helpful. We were hoping to engage conversation with you all, and I'm sure you will have other questions that you might think of later. So please feel free to contact us if you have any questions. At this point, I'm going to turn things back over to Ashley for some final comments.
Thank you, everybody, for a great discussion. I just have a few last announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation is already posted on the event webpage, but within the next few business days, a recording and transcript of this webinar will also be added. Please make sure to join us for the upcoming New England Nursing Home Quality Care Collaborative webinar on September 10th. Thank you so much for attending, and have a great day.